Great to see you all. Thank you all for dialing in this evening. So, this evening, our topic for In Conversation With is going to be obesity medication and more, and our role as pharmacists in looking at that whole person look at obesity care. So just to kick off, a few basic domestics just to make sure we're all on the same page. So the webinar will be recorded this evening, so you will be able to access it again if you want to. Could you please now check that your mic is on mute? You can leave your videos on or off if you want to at your own discretion. If you're having any issues with the sound, would you just check the speaker on your own system and make sure that is operating correctly? If you still have ongoing issues, maybe just log out of the call and then log back in and we'll see if that addresses the issue for you. We will have a Q&A section at the end, so feel free to pop your questions as you go into the chat function, or you can save them until the very end of it. We will be doing a short survey. It'll be anonymized data just for the IOP on the webinar. So we'd really appreciate if you could complete that at the end of the webinar for us, please. So tonight, I'd better introduce who we are in conversation with. So we're in conversation with Dr. Jean O'Connell. She is the consultant endocrinologist at St. Columcille and St. Vincent's University Hospital in UCD in Dublin. Now, so what I'm going to do is hand over to Jean now and let her take us away for the rest of the evening. And I will see you all again at the questions section at the end.
Thanks, Ruth.
No worries, Jean. I'll let you
Hi,
know.
everyone. I'll just start by sharing my slides.
It's looking good from my end, Jean.
Okay, great.
Super.
Thanks very much. So yeah, as Ruth was saying, I'm going to talk for a little while with some slides, and then at the end, I'm going to leave plenty of time for questions because I suppose when I was putting this together, it was great to get some of your responses into what you were interested in hearing about. And then I had some thoughts, but of course, there'll probably be some stuff that maybe I won't cover that you want to ask about. And definitely we can have a good Q&A at the end if that'd be helpful. So I'm going to start, and I suppose what came back very clearly was that everybody really wants to hear about pharmacotherapy, which makes sense, of course, because this is a pharmacist audience, so we're definitely going to talk about that. But I always think that in order to really understand obesity pharmacotherapy, we first have to really understand obesity. And part of understanding obesity is understanding how we can do harm if we don't understand it. So I'm going to kick off by showing some statements about some other diseases in addition to obesity that some of them might sound a little strange, but the ones maybe that particularly would jump out to you would be around people with depression just needing to pull themselves together, and you can catch HIV from shaking someone's hand. And people with obesity just need to have more willpower. Now, these statements, what they have all in common is that scientific study proves them to be false. But unfortunately, when there is stigma attached to a disease, it sometimes can persist even after the science has counteracted that stigma. And this can cause significant problems for the person living with the disease. In the context of people living with stigmatized disease, they will often report that dealing with the stigma and living with the stigma is much harder than living with the disease. So part of what I'm really trying to achieve when I talk around stigma is I want to get to a point where that statement about people with obesity just needing to have more willpower sounds as crazy as the one about people having demons living inside them causing seizures. And well, what is stigma? It's certainly something we all are aware of in certainly in other guises as well as with obesity. And I suppose it's a superficial attributes and characteristics are often the case that we can judge people, individuals, and it leads to prejudice, social and health related harms, which is where it really becomes relevant for us, active discrimination and microaggression. So particularly if you consider a disease that's very visual, such as obesity, where people are dealing with microaggressions and stigma on a daily basis, sometimes multiple times across the day in every setting that they are in. Why is this important in the context of health? Well, there's been a huge amount of research that's done over the years in the area of how stigma affects health. And these are some quotes from some leading researchers in the area. But the take-home message is that it's an independent social determinant of health. It independently predicts adverse impact on health and even increase in mortality. So when we really take that seriously, we then, as health professionals, realize that we need to address this as well as part of improving health. And stigma is present at all levels of society, so I suppose it needs to be reduced addressed at all levels. Now, the biggest reach, of course, would be in the area of policy or society, would be public health campaigns or maybe legislation if appropriate. But I do think that from the ground up, individual, interpersonal, us talking to friends, family, colleagues, and then institutional, which would be in the setting of our universities and healthcare settings, and in this case, pharmacy workplaces, then we can really make a big impact if we're influencing how we're thinking, understanding, talking about obesity. Is weight stigma different to other forms of stigma? Well, I suppose the big thing to highlight is that unfortunately, it's the only form of stigma that is still widely acceptable. There was a survey of over 3,000 people living with obesity, and they were asked to identify where had they experienced stigma in their lives. And 72%, that was the highest proportion, identified that family. So family was the biggest source of stigma, which actually, if you think about it, in other stigmatized conditions, often family would be a safe space, a source of support. But in this case, it's often where they experience stigma most, even though it's usually not intentioned in a bad way, but it can still have that effect. 54% experience in work, 64% in school, and that wasn't just from the peers, it was also from the teachers. And then the top right image is from a different survey that was looking at media imagery, which was looking at the type of imagery used whenever obesity was discussed, whether it was newspapers, magazine, TV, online, and 72% of the time it was a stigmatizing image. So you can picture the type of image where usually the person's head is not included in the picture. It's often just their trunk. They're wearing badly fitting clothes, holding really unhealthy food, maybe lying on a sofa, unhealthy behavior, really reinforcing those negative stereotypes. And of course, we're all so influenced by media that is having an impact in what we're thinking and then how we behave and act. So we get to healthcare settings, and the question is, well, we pride ourselves on practicing evidence-based medicine, so this should be a safe space for people living with obesity. But unfortunately, that same survey that I mentioned, and I hate to say this as a doctor, but unfortunately, we're second only to family members as being sources of stigma for people living with obesity. In this particular survey, you can see that nurses and dietitians come further down. They haven't included pharmacists there, but there are a lot of surveys across the board of health professionals and also healthcare students. And there has been evidence of bias and stigma. It's throughout the health professions, unfortunately. I suppose just as it reflects, public opinion, and we're all living in the same society. These surveys are usually assessing what we would call explicit bias or overt bias, which is where I have a negative opinion about somebody and I express it, such as I think people with obesity need to have more willpower or don't have enough willpower. And actually that form is probably going down a little bit. But there's another form of bias, which is implicit weight bias. And implicit bias, by definition, is subconscious. We often aren't aware that we even have it. And that's why it's so important that we talk about it as a foundation before we go on to talk about something like pharmacotherapy, because when we hold implicit or subconscious bias in terms of how we think about something, it does influence our actions, even if we're not aware of it. And they've actually studied health professionals who hold implicit weight bias and shown that they're less likely to arrange appropriate investigations, less likely to start appropriate treatments, spend a shorter amount of time with people with obesity in a consultation and are more likely to blame every symptom that the person has on their weight. So I want to give you an example of implicit weight bias. And sorry, I'm going to break a rule that I have, which is to never put too much writing on the screen. But these are all quotes taken from referral letters that are sent into the Centre for Obesity Management where I work. And you're probably not going to be able to read all of these, but it was more to give an impression of, kind of the barrage that I have on a daily basis of indications of implicit bias. Now, some will be obvious and some may be less obvious, but I will just highlight the bits that jump out to me. So at the top there, the use of the words denial and failed, we don't tend to use those types of terms in the context of treatment of other diseases. If we would say that a treatment has failed, or we would say that a person didn't respond to a treatment, but we don't say that they failed. You can imagine saying a patient who was given a cancer treatment failed to respond to the treatment. We don't say they're in denial about it. And so these are the types of terms we tend to use with obesity, and to some extent I see it as well in diabetes. There's a lack of person-first language there. We'll talk about that a little bit later, but it is important to not define someone by their disease. So saying someone has obesity or has diabetes rather than is obese or is diabetic. Despite discussing, I often see this and I know what they mean, but again, it's that implicit assumption that weight is going to respond to a discussion. And again, if we think of other chronic diseases and treatments, we would never think that we could talk somebody's COPD or heart failure better. Yes, we would talk to them, of course, about healthy lifestyle, because that's important for all chronic diseases, but we wouldn't expect a treatment to lead to improvement if it was just a discussion. Grossly obese, I think further down you'll see morbid obesity. These kind of terms, really, really negative, very stigmatizing for a patient. Again, despite guidance, advice. Often you'll see she has tried everything or he has tried everything. So there she has done Weight Watchers, Slimming World. But again, they are not recognized, scientifically proven treatments for obesity. So it's important that we're not reinforcing to people that as a treatment when they feel frustrated and exhausted from trying various treatments that aren't treatments. And no wonder they feel like giving up. Again, it's saying can be motivated and lose a few stone. Again, equating motivation with weight outcome. Doesn't take much to set her back. So I'm going to talk about this a little bit, the idea of metabolic adaptation and how biologically humans are just programmed for weight regain to happen. So that is not unique to this person. It's normal human biology. He claims that lifestyle changes are difficult as he is currently caring for his mother. It's just so judgmental and, again, not believing the patient. I can't seem to get through to him regarding his weight. This is because his weight is not reducing, but he could have a type of complex obesity that is not responding to lifestyle change. Bit more controversial one there about the medical council, and I'm very happy to talk about that in more detail, but I do feel that the communication that you're probably all aware of that was sent out a couple of years ago had a lot of implicit bias in it, and that was about recommending not to prescribe off-license medications in this context. I'm not aware of that being done for another medication, but maybe you guys would know more about that. Excess body weight is an old-fashioned term that we need to move away from. So it implies that the person has to be within an ideal weight category, and we're going to talk about that as well, which is something hopefully we've moved away. And this doctor actually was delighted that they were responding to semaglutide and only eating one meal a day, and that was said as a positive outcome. So again, really not understanding that that's causing more harm because the person wasn't getting enough nutrition. And this is the one that I thought was the most shocking, but just to put it down there so that we really do see that this is what patients are dealing with, where a doctor wrote directly to them. I was copied on the letter saying, ultimately, your weight is going to result in your untimely death. Unfortunately, I do feel it's important we put straight facts down on paper. So I'm not overstating the amount of stigma that people are dealing with. And I think it's helpful for us to see this because when we are speaking to patients living with obesity, we maybe have some sense of what they're bringing with them. So, when someone walks into your pharmacy and they may have just encountered something stigmatizing outside, they may have had an encounter with their family member, they may have had very negative experiences with health professionals in the past, and that's going to influence how they're going to interact. So in a way, sometimes we have to maybe take that into account and be even more sensitive than we are in many areas. So I talked about explicit bias and implicit bias. The third form, which is probably the most damaging form, is called internalized weight bias. And this is where people living with obesity are living in the same society, culture that we all are. They're exposed to the same negative stereotypes and internalize those views so that they now are holding those negative beliefs against themselves. So this can be particularly damaging. All stigma experiences can have very negative effects on health, but if a person has internalized weight bias, it increases the risk of the following adverse health effects that I'm going to show you quite significantly. So on the left, you see all the adverse psychological effects, and I suppose that makes sense. We would expect, if we were experiencing stigma over and over again, that we would have increased risk of many mental health outcomes. But what some people would not be aware of is the stress-induced pathophysiology. So when we experience stigma, there's an increased risk of increased cortisol, so the stress hormone cortisol, increased glucose, increased blood pressure, and increase in inflammatory markers. And this has been shown in a number of studies. Also, increased risk of maladaptive eating patterns, such as skipping meals, binge eating, or relapse of binge eating episodes. And people are much less likely to engage in physical activity after they've experienced stigma. And this has been studied in children, adolescents, adults. It will have that effect across the board. And then much more likely to avoid healthcare, which makes sense, I suppose, if they've experienced stigma in healthcare settings. And this is particularly significant in a population who potentially really need support of healthcare professionals. And it's also been shown in avoidance of cancer screening appointments. Again, in a population who have an increased risk of certain cancers, they're less likely to attend for cancer screening because of negative experiences. So all of that feeds into a vicious cycle, and this graphic is just sort of demonstrating that, where experience of stigma contributes to adverse health and weight gain, because those behaviors that we saw there that are going to increase weight, and then more stigma, and then the circle continues. So what can we do? Well, as healthcare professionals, we can explore our own beliefs and our weight bias. So important that we recognize as humans, we all have biases. We all have implicit biases. That's completely normal. These things are formed over many years, but we can start to examine them and think, does what I believe, is it held up by the evidence, by the science? So having an awareness of the complex genetics and biology of obesity can be helpful, and definitely just an awareness, because even I struggle to understand it fully. It's really, really complex. But in other diseases, we kind of have a healthy respect for how much we don't know, and I suppose it should be the same in obesity. Just on the genetics, I'm going to very quickly show you a couple of graphs. I don't want to dwell on this because obviously we could talk a long time about it. But these were studies that were done in 1990. I don't know if they can still do these types of studies today, but basically they got twin pairs, and for 100 days they were kept in a university environment where they were just sedentary the whole time. They had no activity, and they were overfed by 1,000 calories per day for 100 days. So I suppose the first surprise there, you'll see the graph on the left is weight gain, and then the one on the right is in terms of adipose distribution. So this was visceral adiposity. And basically what you're seeing was a correlation. So the twin pairs gained the same amount of weight, or very closely gained the same amount of weight, but across the different twin pairs that weren't genetically related, there was a big distribution of weight gain. So I suppose what that's saying is that if all of us did that experiment where we were overfed for 100 days, we would gain different amounts of weight. So it's very much dependent on our genetic predisposition, supported there by the fact that the twins gained the same. And then they did the reverse of that experiment where they exercised them. So they kept for 100 days, they kept their intake the same, and then they exercised them every day. And the first thing is they only lost a small amount of weight because, as we know, exercise isn't great for weight loss. It can be more in some people. As you can see here, there was some twin pairs that lost a bit more weight and some twin pairs that lost less. But again, very genetically determined, because the twin pairs were very tightly connected, whereas when they weren't genetically related, it was quite differently distributed. So again, some of us will lose some weight if we exercise intensely, but most of us won't. And then this is a great graphic or visual image that I think of. Sometimes people struggle to really understand the idea of the genetics and the environment and how they're interacting. But this is a way I think about it. So if you're lucky enough in the context of weight and obesity to be the container on the left, and then you're in an obesogenic environment, you only have capacity genetically to gain a certain amount of weight. But if you genetically are programmed to be that larger container on the right in our current obesogenic environment, you will be programmed to get to a much higher weight, and then potentially all the health impairments that go along with that. So absolutely genetics, and that's about over 70% is determined by genetics, and then it's interaction with environment after that. So we really need to move away from this losing weight is simple idea, this energy in, energy out. All you need to do is eat less, move more. I think we kind of all know that we're not supposed to think that way. The problem is getting to truly believing it. So the thing we have to remember is that the piece that's left out of that means it's not simple, is this really complex homeostatic regulatory pathway that's happening in between, that in the past was not considered. Just like we're all sitting here with our bodies being controlling our breathing, our heart rate, our calcium levels, our sodium levels, our fluid shifts, all of that's being controlled without our conscious decision. However, if I asked everybody to slow down their breathing, you could probably concentrate quite hard, and you would be able to do to some extent. It would be hard, but you do it. How long could you do it for? Could you do it and then keep your breathing rate down while doing other tasks? That's probably a good way to think about how we do have a certain amount of control over energy regulation and weight, but the vast majority is at a hypothalamic level that's communicating with all these other networks. And that's then influencing what we perceive as behaviors in many cases. So we often will compare our sense of hunger, our sense of satiety to somebody else. But of course, they could be genetically programmed to not feel hunger the same way. And in fact, we get that feedback from patients all the time after they have a really good response to either pharmacotherapy or surgery. They say, I never felt hungry before. I didn't know what people were talking about when they described that. And now I feel more normal. So it is that biology influencing behaviors. The other way to think about obesity, the disease, is again, think about heavily influenced by genetics. And then, of course, to make it more complicated, epigenetics, and there's neuroplasticity and other acquired factors. But what that's then influencing is how the brain regulates appetite. And that dysregulation is fundamental to the disease. But then in addition, we have adipose tissue dysfunction, and that can be influenced by how the adipose tissue is distributed, whether it's inflamed, producing inflammatory markers, or other metabolic dysfunctional components, and then the communication between the adipose tissue and the brain, and then also communication with muscle. So muscle produces lots of factors that are talking to the brain, liver, gut. And there's a huge amount of research now looking at the microbiome and how that's influencing both appetite regulation and even extraction of calories in the gut. So all of this is influenced initially genetics, then epigenetics, other acquired factors that can change things as we grow up and in childhood. And then there's all this environmental interaction that, of course, makes it super complicated because people will respond to the environment differently depending on their genetic predisposition and other factors. So I suppose if you're looking for a definition of what is obesity, then that middle one there, excess and or dysfunctional adiposity or fat tissue that impairs health. That's the best way of thinking about it, because we have people who are living in larger bodies who are actually completely healthy, and that weight is okay for them and they're fine and they don't necessarily need treatment. And it's really important that we don't make an assumption about their health based on the size of their body. And that's unfortunately what happens when we zone in too much on BMI. So you'll notice that that definition does not include weight or BMI, because it's a recognition that it's about health impairment and it's about excess, but also dysfunctional adiposity. So that can happen at lower BMIs, and you could have a person with much worse health impairment at a lower BMI and a person at a higher BMI who actually is doing better. And so that's where we have obesities rather than obesity, a bit like having the different types of diabetes. We can have different drivers and contributing factors, and that'll make each person's obesity a little bit different. The other thing I think that can make it difficult when we're, and I'd say in pharmacies you encounter this even more, is this confusion that is driven by the media really latching on to particularly the new medications. And really what they're often talking about is around the cultural desire for thinness. And I suppose what we as health professionals need to keep doing is to really recognize that what we're doing is focusing on obesity management. So we're focusing on health impairment and improving health. And we'll be guided by things like the model of care for obesity management or clinical guidelines, and try as much as possible to avoid the confusion that the media brings. So what else can we do? Well, managing obesity with a chronic disease model of care is so important. And again, this is fundamental when we're thinking about pharmacotherapy or any intervention, because it helps us understand why it needs, in the majority of cases, to be a long-term approach. We're well used to this with other chronic diseases. And also the focusing on health gains rather than one specific parameter, such as weight loss. And in doing so, we need to manage our expectations as well as patients and our colleagues in many cases who may have a different understanding. This is a standard weight loss curve. This would be the same for any human who tries to lose weight or has an intervention that will lead to weight loss. It'll be different if they maybe have a dietary intervention. The plateau will happen higher. Then pharmacotherapy and surgery tends to bring people down the lowest. On average, obviously, it'll vary person to person. But the main thing to remember is that as soon as the weight loss happens, those homeostatic mechanisms, internal alarms go off, and the body increases hunger hormones, reduces the satiety or fullness hormones, and reduces our metabolic rate. So we're now much more fuel efficient and ready to snap back, where it took maybe ages to lose. It could be maybe 6 to 8 months to get down towards that plateau. But if anything happens that we ease back a bit, the body will be ready to snap right back, so that if the person starts to regain it, it'll go back up much quicker. And we've all seen this either in ourselves or in other people. It's a really common approach. But I think it's so important that we remember this is a biological mechanism that's the same for everybody, including people with obesity. And we need to help people to understand that this is an expected response, and it's an expected response with interventions. So it doesn't mean the intervention has stopped working. It doesn't mean the medication is not working. We hear this all the time. And we just need to talk to people and understand ourselves about the chronic nature of the disease. And maybe that plateau is is where that person can get to at this time. Or maybe we can think about another treatment to then go down again. But not always. So it's something that we have to be realistic about. And that's why we have this concept of best weight rather than ideal weight. We want to move away from the idea of ideal weight, which was predicated on the notion that everybody had to have a BMI within 20 and 25. But of course, there are lots of people who will be very, very healthy at BMIs above that. And equally, at the other end of the spectrum, we have to remember that if we take an example of somebody maybe who has a BMI in their 50s, so say BMI of 55, and they've had maybe combined intervention of bariatric surgery and pharmacotherapy, and they're following healthy lifestyle and behavior supports. But in spite of all of those interventions, their BMI is maybe now 42. They've got significant improvement in health impairments that they had at baseline, and they've maybe come off some of their maybe diabetes or other medications. So lots of things are better, but their BMI is still well above, again, what would be considered in that normal BMI in the past. It's so, so important that we all have to understand that that is their best weight. And, for the current treatments available, that is their best weight. And that's what we need to aim for. Again, we're used to it in other chronic diseases. For example, in chronic heart failure, we're not trying to give people a brand new heart. We know that's not possible. We're trying to help reduce hospital admissions, reduce exacerbations, improve their quality of life. But we know that, part of that, certainly that's a long-term approach, and we won't always get things to exactly where we want them to be, depending on the complexity of the disease. So just a pause at that part to just come back to that idea of understanding obesity, and hopefully some of that information, which I know is really just the bare bones of the concepts, but to think of body weight as being homeostatically regulated and genetically determined. Physiological adaptations will then oppose sustained changes in weight. So that's why we need other interventions to help overcome that to some extent. People do not regain weight because they lack willpower and motivation. Again, it's back to that biological response to weight loss. And obesity is a chronic disease that will not be cured by weight loss. So even if someone does lose weight with an intervention, they still have obesity. And that's why treatment often needs to be ongoing. And as I said, we're used to that with other chronic diseases. We just need to manage obesity the same way we do them. And unfortunately, we're in this transition period where we have recognized we need to do that, but we're not quite doing it yet, certainly in terms of resourcing. But the model of care that was published in 2022 is now describing and being implemented partially, but we're still advocating, and hopefully we'll see full implementation over the coming years. And that is going to describe a much better resourced both primary care and specialist care for people living with obesity, so that they can flow easier between them and not have long waiting times and difficulty accessing medication reimbursement. There are clinical practice guidelines that are available online, and you can see there is including one pharmacotherapy chapter. These were adapted from the Obesity Canada guidelines, and the pharmacotherapy chapter is a little bit out of date. We're hoping to update it. Obesity Canada updated their chapter just this year, so we're hoping to update that one next year. But for now, there is still some helpful information there. Also, the website in St. Columcille Hospital has some information, which for both patients and health professionals. And it's something maybe to be aware of, just that you could mention it to patients to check it out, particularly if they're on our waiting list. But for even patients who aren't, there's some helpful information there about holistic management and community supports. And the website, the Irish Coalition for People Living with Obesity, I work with them quite closely, and just want to give a shout out to their website, which can be really helpful for, again, people living with obesity, and particularly if they have a lot of internalized weight bias where they're really blaming themselves. They can get a lot of good peer support from contacting the ICPO through their website. I normally sometimes will co-deliver presentations with advocates from ICPO, but obviously not this evening. So I just want to give a shout out to a podcast that I did with one of the advocates from ICPO, Susie Burney, and if anybody wants to check that out and hear her voice describing her experience. So just finally on that, what can we do? I suppose the respectful and sensitive communication is so, so important. And I think if we have that understanding, it will then manifest through our body language, our tone, and the words that we use. There's also really good HSE Land MEC module talking about overweight, obesity, and obesity that has some good phrases and conversation openers. And there's a really great website in the UK, Language Matters Diabetes, and they have some brilliant stuff for diabetes predominantly, talking about different aspects of language and how we talk to people and the impact that has on people's sense of empowerment and self-efficacy. And there's now a Language Matters Obesity as well. That's the UK one, and I think they're working on an Irish version as well. So I always think people forget what you said, people forget what you did, and they'll never forget how you made them feel. This quote from Maya Angelou is so important, particularly at this point, as I said, of transition, where sometimes the people we're talking to will not have access to the treatments they need, or they'll be on a waiting list for those treatments. And in that case, sometimes we won't be able to maybe do something very concrete in terms of treatment, such as give them medication, but we can relate to them, we can listen to them, we can understand what they're going through, we can acknowledge that they are living with a disease. And that's hugely important. That really is not nothing. That is, you could be the only health professional that they've had that type of interaction with, and it really does make a difference. So moving on to obesity management, and in terms of these pillars, so nutrition, movement, and participation, sleep quality, and circadian health are the foundation. So whenever we're talking about any treatments, including pharmacotherapy, we are not saying that these things are not important. Of course, they're always there as a foundation, just like with all chronic diseases. But and this, all management has been reframed, fortunately, now that when we're talking about treatment, it is in this context that we have to also have public health interventions. We have to have appropriate behavioral support. So it's not instead of. And actually, even the behavioral support has been reframed. So particularly with effective pharmacotherapies, it's less important talking about reduced calories. It's much more important checking that people are eating regular meals, healthy snacks if needed, just the quality of their food, less processed food, and supporting with checking about getting enough protein, because that can help with cravings, etc. Similarly, a lot of people with obesity won't be able to do that goal of 150 plus minutes per week, but talking about healthy movement, muscle strength and conditioning, balance training, all these things can be done at any weight or level of complexity. So in terms of the pharmacotherapy, I usually start by referring to this. Oh, I'm thinking you probably won't be able to read anything on that table, but that is in the clinical practice guideline in the assessment section of the guidelines. And the reason I think it's just so important is so many of our patients with obesity are on weight promoting medications, and often we'll be talking about treating with obesity pharmacotherapy, but the patient might be on mirtazapine, pregabalin, quetiapine, and wondering why they're not getting as good a response. I do spend a lot of time writing to GPs and mental health professionals, asking them if they can review their medications. And in many cases they do, and sometimes it has quite significant outcomes. Of course, I recognize that they can't always be changed. It's really just a query that someone has to think about it and a chat with the patient, and that it's a collaborative decision to continue. So I think everybody knows the basic criteria in terms of prescribing. And in the case of liraglutide and semaglutide, we can go to lower age depending on BMI, so it would have to be much higher. I've italicized the only continue of significant weight loss. I know this is important, that obviously we don't continue medications if they're not having a significant effect. But it's always worth remembering or checking what's the weight trajectory prior to the medication starting. So sometimes patients, their big problem is that they're gaining weight. And if a medication actually helps to get weight stability, then that can be really significant. But I know with the reimbursement criteria, that's not currently considered. So we have orlistat and naltrexone bupropion or mysimba, two medications that really are not discussed or probably prescribed as much. Maybe you do see this in pharmacies. I'm happy to talk about them if anybody has any questions. I prescribe a little bit of mysimba, but there's so many cautions and relative contraindications, and particularly in populations with obesity, it sometimes can be a difficult medication to prescribe. And I've also had people experience quite a bit of side effects, so it can be tricky, but happy to answer questions about those. Just moving on to the NUSH hormone therapies, because I suppose these are the ones that are most topical. In the past, we would have said GLP-1 therapies is the umbrella term, but of course now we have not just one agonist, but we have dual and triple agonists. So nutrient-stimulated hormones are the hormones that are stimulated in the gut when we eat. So these are the same hormones that we're using with these therapies, and we'll be familiar with the ones that act on GLP-1. But then in the case of tirzepatide, we now have dual agonists, which is GLP-1 and GIP. And then there's other ones that are quite close in the pipeline, including the triple agonist retatrutide, which is the GLP-1, GIP, and glucagon agonist. And it seems that you get added effects as you have multi-agonism. And we have multiple effects internally in the various different organs as well, which is why we see lots of other effects, definitely way beyond weight loss in terms of cardiovascular disease, benefit, etc. So we have liraglutide and semaglutide as the main ones. And I just have again, this table is taken from the guideline. I don't want to spend too much time on these kind of details because we can chat about it in the Q&A, and these are available in the SPC anyway. Actually, this guideline was done before we got tirzepatide, so I've just added that in. But it has the same types of cautions, contraindications, side effects, etc., as semaglutide and liraglutide, and the dose ranges 2.5 to 15 milligrams. Question about whether patients are represented in the pharmacotherapy RCTs. Really, I just wanted to make this point because a lot of the evidence that we're using, of course, is from RCTs, which is very strong evidence. But it's just worth remembering that the populations that they studied in STEP and SURMOUNT were very clean populations. In SURMOUNT, people who were taking weight-promoting medications were excluded. There's very low percentage of older people over 65, and a third of the patients had no obesity-related complications. So just always bear that in mind with the pharmacotherapy RCTs, that they're not as representative maybe as of the complex patients that we're seeing. Gosh, I'm just looking at the time, so I'm going to scoot through a little bit. So maybe just we can come back to the slide maybe in the Q&A if anybody wants to ask about any of these upcoming medications. But this is sort of what's coming in terms of getting, I suppose, eventually to, if we're just talking about weight loss, which we try not to focus exclusively on, but that's what's very topical. And retatrutide, that triple agonist, is the one that's hopefully going to be very effective in that context, although again, cost will probably be an issue. Adverse effects, we're all familiar with the GI side effects, and these are the things that we can help support people with, particularly around expecting a certain degree, but also slowing the dose escalation. That really, not everybody has to get to the top dose. Often people feel that they do, but of course, I've some people who are on lower doses and doing really well. I think if people are more sensitive, it's much better. And we say to them, it's not a race, because if they keep going and get really sick, they'll have to come off it altogether. There's a really good paper here that has some nice tips about how to support people to manage side effects, with lots of different practical advice around avoiding certain trigger foods, eating slower, all the usual kind of advice you'd expect. So I'll just kind of scroll through that. Unfortunately, pancreatitis is still a little bit challenging, because even though the evidence isn't very clear, the recommendation is still to avoid in anyone with pancreatitis. So that can be a problem for people who do have that history and they're not able to access the drug. And of course, gallstones we see just with any kind of significant weight loss. I had a piece about surgery, but I'm not going to have time to go into that. What I might do is I'll just refer you to, this is on our website, St. Columcille's Hospital, and it just, because it has the list of all the vitamin supplements that people have to take after bariatric surgery. And it's really important because often they're told by somebody else they don't need to take them long term, but they are lifelong. So all that information is there. And I think it'd be really helpful if you have a patient who's had bariatric surgery that you would know that too. So I suppose takeaways then would be around just the obesity narrative being different, and healthy behaviors are important, as with all chronic diseases, but we need our additional treatments. And I suppose we have to all keep advocating so that we are improving access. Sometimes it probably feels like we're in a really empty place where people can't access different treatments. But I think we have actually advanced so much in the last few years that I am optimistic that we are going to get to a point where obesity care is the same as other chronic diseases. So with that, I will stop sharing.
Thanks so much, Sheen. That was brilliant. I learned a lot there to hopefully improve my practice as a pharmacist from your descriptions of some of the biases that we can innately have, whether we recognize it or not. It's our human factor, I suppose, to a certain degree. So I'd love to open the floor now to anyone who would have any questions for Jean. So if you're comfortable, you can pop on your mic. If not, you can pop it in the chat box. And we'll pick your brain for your expertise to kind of get us a better understanding of where we're going. I suppose, Jean, when our patients present to us in the pharmacy, what do you feel our approach, if it's a new patient with a new prescription? You're probably at the other end getting feedback on what the experience is like for them. If you had maybe a takeaway for us or one thing we could do as a community or practice that would help support that patient in that very first initial interaction. Because like with all patients, once you get to know them, you build a rapport with them, but it's in that first few moments that we leave an impression. And from what you hear back, is there anything we could do that would be more supportive of those patients in those initial moments when they come in to us?
Yeah, it's interesting, because some patients will describe amazing relationships that they have with their pharmacist, and it's so lovely to hear that. And I think building that relationship is fantastic. But if you're meeting somebody for the first time, I think it comes back to that idea of, the Maya Angelou quote about how people feel. I think we all have, it's a privilege in a way that we have the possibility to really put someone at ease and as I was saying, potentially be one of the few health professionals they've met who is really sympathetic, understanding, open, non-stigmatizing, not judging. So maybe if they came in, you could say, "Oh, great. How are you feeling about this?" Or, is there anything you don't understand? The usual things that you would, but maybe being extra aware that they are going to be very nervous coming in,
Okay.
maybe more so than if they were just coming in with a blood pressure prescription,
Okay.
because I think sometimes doctors will sometimes say that to me as well. They say, I don't understand why I have to ask permission to somebody before I check their weight. I mean, I don't ask permission if I check their blood pressure. And I was thinking, well, maybe you should be asking permission for your blood pressure too. But there is actually a difference as well, because weight is really sensitive. It is a really
Mm,
sensitive subject. So I think being conscious of that, and I know it probably depends on the pharmacy. If there is a private area, if you feel somebody needs that, that would be amazing to give people the option, I suppose. But perhaps that's not always possible or at the time of
mm.
day.
Okay, thank you. Some questions coming through now. Now, I know this is probably outside your scope of practice, and if so, that's fine. We appreciate it. The PCRS, it's a PCRS question. Who are the people who pay us? Are they looking to prove any more brands of these kind of drugs, such as a Manjaro, or maybe this is outside your scope?
No, I know there's a technology assessment ongoing, well, actually probably nearly finished for Manjaro, so that is imminent, and that would help inform So I know they're considering it. Probably the bigger question is whether it will actually happen. Uh,
Mm.
I would certainly be more optimistic about Mounjaro than I would be, say, for Wegovy, because with Mounjaro, it is a diabetes treatment as well. And I think maybe I'm being optimistic, thinking it'll be hard for them to justify not um, including that in terms of reimbursement, certainly for people with diabetes. And then outside of diabetes, I think the thing that's going for Mounjaro as well, because I suppose the additional weight loss and health impairment, reductions in certain health impairments will make it potentially more of a health economic argument. So I kind of have to believe that it will happen eventually, but probably the cost needs to come down as well, doesn't it? I mean, the cost is just not possible for a large number of people the way it is at the moment. And then I suppose probably initially we might have to stratify it in terms of need or complexity, maybe not as broad as we'd want it.
Okay. Okay, if we have a patient and you describe that idea that they plateau with their weight and they were on injectable just as Ozempic or something, would you then move them over to the Manjaro? And if that doesn't really work for them, do we keep them on some kind of an agent long term to stop their body reverting, as you said, it innately will want to?
Yeah, this is really interesting because at the moment, one of the things that's bothering me is that, and again, this is the media coming into it. You'll probably have heard Manjaro being described as the King Kong of medications, or the Rolls Royce, or people have that. I've had a lot of patients come in who have been started on Manjaro, and it's because they asked for it from their doctor.
Okay.
And I'll say to them, did you consider another medication that might be more affordable? And they'll say, but I was told this was the best one.
Okay.
And the thing is, we just don't know. I mean, yes, like I said, in the RCTs, the average is a little bit higher in the Manjaro trials, but the patient in front of us may have as good, or in some cases, a better response to maybe semaglutide or another one. So you just don't know until you try it with someone. And I think at the moment we really have to take into account the affordability side of it. And so I suppose in answer to this question, if they do plateau, yes, because there is potential that they might get additional weight loss and health benefit from a change to Manjaro, it is a possibility, but I would always explore the affordability aspect with a patient. I think sometimes people are being recommended or switched to something they can't afford, and actually in some cases then it's not being monitored, so they're continuing on it and they've already had significant weight loss with Ozempic, so they're actually not losing much more weight on Manjaro, and they might as well just be on Ozempic because the plateau is the same, but that's not being reviewed. So I think we have to look at everybody individually, try things, talk to the patient, what can they do, and and take each one that works best for that patient.
Okay. Lovely, 5 years ago. Okay, what if we have a patient who's on a pharmacotherapy such as the Saxenda and they're not seeing the weight loss? Do we then think to move them across to something like the Manjaro?
Um, yeah, so again, I suppose this is similar to the other one. I suppose the difference is that Saxenda, as unfortunately, is again in studies tends to have less of a weight loss response than we'll say liraglutide is has less weight loss on average in a study than semaglutide or tirzepatide. Now, that's on average. I definitely have seen some people have really good responses to liraglutide or Saxenda, and so it is possible. But if they're not seeing it, then definitely they potentially could have a better outcome. And this is where I suppose again I'll say this is I would go with, particularly if affordability was an issue, I would also include suggesting Ozempic, even if they didn't have diabetes, because I prescribe Ozempic off license all the time because I believe if the patient can afford Ozempic and they can't afford Manjaro, and they may get significant benefit from it, I do not believe that that's unethical. I think it's unethical to withhold a treatment from someone if you think it could benefit them. But I think that's where I differ with the medical council.
Okay. And
I
another
should
question
say I'm not
then.
the only one who thinks that, by the
Yeah,
way.
there's no doubt you're the expert in the area. Have you any updates on the oral drugs that are meant to be coming through?
Um, so I think the big one is the oh God, I always struggle with orforglipron, the non-peptide GLP-1 agonist. So it's not like the oral semaglutide. So oral semaglutide, as you know, is available, but it's difficult to access. It has to be taken on an empty stomach. It has a lot more GI side effects. Bioavailability is very poor, so that the dose is something like 50 milligrams. I mean, it's a tricky one, and it's not. It doesn't seem to have taken off the same way. But this other newer one, this non-peptide GLP-1 agonist, is not. It does not have the same problems because it doesn't have the same absorption issue with the stomach. So that is, I think, just finished a phase 3 trial, and that means I suppose it's close to being available. But again, it I suppose the question is cost, but you would imagine it would be cheaper than the pens. So yeah,
Mm,
maybe within the next year or two we might have a good oral option.
okay, perfect. A question about the combined GLP-1 and the GIP pharmacotherapies. Have you seen any impacts on mental health? A pharmacist here who's had a patient who's been having conflicting experiences causing negative and positive effects on their mood.
Yeah, that's interesting. I've seen that, not specifically with tirzepatide, actually. I have seen it in the past with both liraglutide and semaglutide, where this is really small numbers now, but I have seen people discontinue because they just felt off or their mood was very low, or so definitely I have seen it, but it seems to be quite small numbers. But I suppose, that the idiosyncratic reactions to medications, it's definitely possible. And I think if it's significant for a patient, I would recommend, I suppose you could try a dose reduction initially, and then stop if it's causing a significant problem. It could be that.
You mentioned the issue of pancreatitis with the GLP-1s. If the patient has had pancreatitis in the past, is it a no-go then with the GLP-1s?
Yeah, this is a really tricky one because currently that does seem to be the consensus recommendation, but the one area where there's a little bit of glimmer is if the pancreatitis was definitely caused by a gallstone and the patient has had a cholecystectomy. I know there are some doctors who will prescribe in the GLP-1 therapies in that context. We don't really have any evidence to guide us in that area because we know that the GLP-1 therapies also have direct effects on the pancreas. So we don't know for sure, I suppose, that they won't. But in those cases, I would often have a big discussion with the patient and help them understand that there is, in theory, at baseline increased risk of pancreatitis, and potentially they have a little bit more of an increased risk, and maybe we could figure that out together as to whether that risk is acceptable.
Thank you so much. Okay, those are our questions, Jean. Oh, hang on. What are your top three tips for patients starting injectables for weight loss?
Oh, wow, with 60 seconds to go.
60 seconds to
Uh,
go.
I the big thing that and you may not have the capacity to do this depending on the situation or the day in your pharmacy, but I just think it's so important that people are eating regular meals. I think this over a third of patients, probably nearly 50% of patients who come to our clinic are skipping loads of meals, maybe only having one meal, sometimes, binges, or um there can be a lot of eating dysregulation. And I think adding a GLP-1 or any of the NUSH therapies in can make that situation worse and can actually support people to eat less. And they're already not getting enough nutrition and particularly not enough protein. And we haven't even touched on the potential for sarcopenia with significant weight loss because of effect on muscle. So encouraging regular meals encouraging enough protein, encouraging lots of fluids and hydration, saying to them that the dose is not, they don't have to get to that dose. It's individual. It's what's right for their body. They can go slower. They can stay at a lower dose for longer. And to come back if they're having any problems with the side effects, that either their doctor or a nurse or in the pharmacy, everybody's there to support them and help them through that.
One last quick one. In practice, have you seen the GLP-1s having a negative impact on people's retinas?
Oh, so there's two issues here. One is semaglutide was seen in one of the studies as having an increased risk of diabetic retinopathy, but we're not sure that probably isn't. There's studies ongoing that are hopefully going to show that that's not borne out and was probably more related to a reduction, or a rapid reduction, because it was in diabetes, reduction in glycemic control, HbA1c, and so that is associated with transient exacerbation of retinopathy. So we think it's probably more related to that, but it's not conclusive yet, but hopefully will be with a new study that's going to be published next year. And then there's the other thing, the non-arteritic, oh God, you know the one I mean, the sudden blindness in one eye. I'm blanking the name of it. That is a serious condition. Does seem to be, I think there was a massive review done by WHO. There seems to be a 1 in 100,000 increased risk. So it is there. I've never seen it. So it's very, very low risk. And in the context of the patients that I'm dealing with, I think the benefits far outweigh that risk, but I think it is a risk. So I suppose I haven't seen it yet, but maybe in future if I prescribe 100,000.
So you haven't seen it in practice, so
Yes.
yeah, that answers that. Brilliant, Jean. Listen, thank you so much. Your Q&A was brilliant there, really answers the particular questions people have, and I greatly appreciate it. I suppose I will remind you of the survey we put in there at the start. If you could take a few minutes, kindly put in by Grace there again. If you could kindly take a few minutes just to complete it before you hang up. Don't forget, please complete a CPD reflective cycle after tonight's session to take that chance. And thank you. This is our last webinar of 2025. So we wish you all a very happy Christmas. We will be back again in January with some more in conversations with. So between now and then, enjoy the moments over Christmas. Take a beat. Enjoy them yourself. Enjoy them with your staff, your patients, your family. And we will see you all again in the new year. And Jean, our great thanks to you for a lovely session this evening and very informative. Thank you all and good night.
Very much. Bye bye.
Thanks, Jean.